In this presentation, the explanation for low HPV vaccination rates among preteens and teens ages 9 to 17 years will be explored, parental medical concerns will be examined, a potential two-phased intervention will be described, and surveillance strategies will be suggested for the World Health Organization. The human papillomavirus is the most common sexually transmitted infection in the U.S. The virus affects both men and women and can lead to anogenital tract and cervical cancer. Consequently, it is important to vaccinate younger age groups, preferably before sexual debut, to reduce the spread of HPV. HPV vaccines are available for both males and females and are given in 3 doses over a 6-month period. Cervarix protects against HPV type 16 and 18, and Gardasil protects against HPV type 6, 11, 16, and 18. Therefore, Gardasil is said to have more protective value compared to Cervarix. The vaccine was shown to be 98% effective for protection against the 4 strains of HPV almost 3 years after the last dose was administered. The target age for an individual to be vaccinated is 11 or 12 years old, but the vaccine is recommended for ages 9 to 26. Most of the literature available focuses on the prevalence of HPV and vaccination for females, highlighting the need for more information focusing on males. There are several barriers to vaccine uptake, including medical and parental concerns. The most common adverse event noted during clinical trials was moderate pain at the injection site. Concerns most commonly reported among physicians were an inadequate reimbursement, cost of vaccine to patient, and burden of determining insurance coverage. Many physicians and patients are unaware that free vaccinations are supplied through the Vaccines for Children program. Additionally, many physicians are reluctant to recommend the vaccine to preteen and teen patients, despite the national recommendations. One of the primary concerns for parents regarding vaccines is safety. Some parents felt uneasy with how new the vaccine was and were concerned about potential side effects. Mothers were concerned that the vaccine would have an effect on their daughter's future reproductive health. Parents have also cited mistrust of pharmaceutical companies, vaccine advertisement, and medical providers. Parents were concerned about the ideal age for the vaccine. Many parents felt like their child was too young and did not need the vaccine now because they believe sexual activity begins at an older age, and their child is not sexually active. Males have less knowledge concerning the HPV vaccine because campaigns initially focused on females. One major reason for low vaccination rates in preteens and teenagers is a lack of knowledge. Parents have not received the education needed to make informed decisions about the HPV vaccine. The literature states that parents would feel more comfortable having their children vaccinated if their physician educated and discussed the HPV vaccine with them. As a result, this intervention has 2 phases. The first will be at the provider level, and the second will be at the individual level. The intervention was designed to test the hypothesis that parents or caregivers who received written educational information on HPV and the vaccine will be more likely to vaccinate their son or daughter as opposed to those who had not received any additional education. For the 2 interventions, it was decided that we would work with populations that have a high risk for cervical cancer. We decided to implement our intervention at the University Medical Center of El Paso and in the surrounding community. Pediatricians and family medicine physicians at UMC will be asked to participate, and for those that agree, baseline data of vaccination rates will be collected. The first objective for Phase 1 is to increase the HPV vaccination rates amongst patients 9 to 17 that visit participating hospitals by 50% by the end of 1 year. The second objective is to improve the knowledge and communication methods of medical personnel in participating hospitals by 20% by the end of 1 year. The first part will consist of training medical personnel, and the second part will consist of the medical personnel discussing the need for the HPV vaccine with the parents. All the participating pediatric and family medicine offices will be randomized into 3 groups. We believe that the group with the educational material and a 1-hour lunch training session will have a higher vaccination rate than the group with only educational material and the group with no contact. There will be 1 intervention for each part, one for the medical personnel and the other for the parents whose children are seen by the participating medical personnel. For Part 1 of the evaluation, all the personnel and the educational material in 1 lunch-hour training session group will receive a pre-test before the start of the session and a post-test at its conclusion. This will be done to see if there was a change in knowledge and if the session was productive. A follow-up questionnaire will be administered 6 months after the initial education session to determine if change in method of communication and knowledge was lasting. Data on vaccination rates will be collected from the participating pediatric and family medicine offices at the 6-month and 12-month mark after the initiation of the program. For Part 2 of the evaluation, interviews of parents whose children saw participating medical personnel will be done. A mixed methods questionnaire will be used and will take no more than 10 minutes to administer. An individual and family-level educational intervention was developed to increase HPV-related knowledge and parental acceptability of the HPV vaccine for preteen and teenage boys and girls. The study was designed to test the hypothesis that parents and caregivers who received written educational information on HPV and the HPV vaccine will be more likely to vaccinate their son or daughter as opposed to those who had not received any additional education. The participants will be randomized into 2 groups. Both groups will receive the educational material and the questionnaire, but the second group will also receive a follow-up phone call from a health educator. In order to estimate the parents' or guardians' perception of HPV and the HPV vaccine, the questionnaire utilizes the health belief model's 5 components: susceptibility, severity, perceived benefit, perceived barriers, and cues to action. The questionnaire will be a self-administered written survey. The first questionnaire will be done to establish a baseline. 4 weeks after the initial questionnaire is mailed, both groups will be mailed an educational flyer on HPV as the intervention. Both groups will be instructed to review the flyer and asked to complete a follow-up questionnaire. Group 2 will receive a phone call from a trained health educator before the follow-up questionnaire is sent to them. Using the responses in the first questionnaire as the control group of the study, statistical tests can be done on questionnaires to see if there was an increase in HPV knowledge and an increase in the participants' intent to vaccinate their children. Statistical tests will also be done to compare Group 1 and 2 in order to determine if Group 2 had a significant increase in the knowledge compared to Group 1. Surveillance of HPV and the HPV vaccine is a useful tool to monitor vaccine coverage, unexpected side effects, and vaccine effectiveness and impact. HPV vaccination programs targeted at the 9 to 17-year-old age group are critical in preventing further spread of the virus, which may lead to cancer. Without adequate surveillance systems in place, HPV and HPV vaccine coverage cannot be monitored, and vaccine intervention programs cannot be evaluated. Monitoring HPV vaccine coverage among the 9 to 17-year-old age group is important in the control and prevention of HPV. Surveillance systems should be implemented to determine whether or not this age group is receiving the HPV vaccine. The U.S. currently uses the National Immunization Survey, or NIS, that is conducted by telephone to gather HPV coverage information in the 13 to 17-year-old age group. The NIS should expand this age range to include male and females 9 to 17 years old. On a global scale, the World Health Organization and United Nations Children's Fund annually report worldwide data from the WHO-UNICEF Joint Reporting Forum regarding immunizations. The JFR should be modified to include reporting on HPV vaccine coverage, particularly among male and females 9 to 17 years old, and offer direction on monitoring coverage of the HPV vaccine. Another important factor to include in HPV surveillance is monitoring the effectiveness and impact of the vaccine long term, which will help to determine if the vaccine is effective in preventing occurrence of disease once a child has become sexually active. Long-term monitoring of the prevalence of HPV genotypes, cervical cancer, genital cancers, and genital warts should be monitored in females. Males should be monitored for prevalence of genital warts and genital cancers. Even though the vaccine is proven to be safe thus far, there is still some risk when it comes to immunization. Therefore, it is imperative that a proper vaccine safety monitoring system is developed in every country. Countries should develop a local and national system for the reporting of adverse events following immunizations, otherwise known as AEFI. This can help investigators and healthcare providers track vaccinations and determine if an AEFI occurred. According to the CDC, every year about 12,000 women are diagnosed with cervical cancer, and about 4,000 women die from this disease in the U.S. About 1% of sexually active men and women in the U.S. have genital warts at any given time. The HPV vaccine has the potential to significantly decrease these numbers if administered according to the WHO and CDC recommendations.